This article explores the use of quantitative imaging biomarkers extracted from chest CT studies. The article begins by describing biomarkers as measurable objective characteristics derived from images that can be used to assess normal biologic or pathologic processes, or a response to a therapeutic intervention. Given that chest CT studies encompass an anatomic region responsible for the top 3 causes of mortality in the United States, namely ischemic heart disease, lung cancer, and COPD, the use of biomarkers derived from chest CT examinations holds great promise. The biomarkers discussed in this article are summarized in the table at the beginning of the paper. The article begins with a discussion of CT quantification of coronary artery calcification to predict future adverse cardiovascular events. Accurate characterization of lung nodules by assessing size by way of nodule volume is a measurand, or quantity that can be measured in assessing growth and therefore predict the likelihood of malignancy for small nodules. Figures 2 and 3 show a protocol proposed by the Quantitative Imaging Biomarkers Alliance, or QIBA, and the link to an online calculator for measuring volume at 2 points in time is provided. The evaluation of subsolid lesions can be difficult, as these lesions, although associated with lipidic malignancy in a majority of cases, tend to grow slowly. Textural analysis using histograms may be able to help identify transformation of part-solid pre-invasive lesions into invasive adenocarcinomas, as shown in Figure 7. Nodule perfusion using dual-energy CT can be used in lieu of multi-phase pre- and post-contrast CT to assess for iodine enhancement and thereby distinguish benign from malignant nodules. Figures 8 and 9 illustrate this in malignant and benign solitary pulmonary nodules, respectively. COPD encompasses emphysema, chronic bronchitis, and several types of small airways obstruction. Emphysema quantification by segmenting low attenuation voxels allows for phenotyping of disease into trace, mild, moderate, confluent, and advanced destructive emphysema subtypes. This information can be combined with areas of air trapping on inspiratory and expiratory scans, which correlates well with FEV1 and FEV1-FVC ratio. Quantitative analysis of the tracheal luminal area from inspiratory to dynamic expiratory CT can aid in the diagnosis of tracheomalacia. Dual-energy contrast-enhanced chest CT with iodine mapping of the lung as a biomarker for pulmonary perfusion correlates with the severity and prognosis of pulmonary embolism, with strong correlations of degree of vascular obstruction and right ventricular to left ventricular ratios with serum troponins and overall patient prognosis. Dual-energy biomarkers of lung perfusion also correlate with the severity of pulmonary hypertension as determined by pulmonary artery pressures. Quantitative analysis of bone mineral density at L1 and L2 that are included on most chest CT examinations can be used for the diagnosis of osteopenia and osteoporosis. This article has an accompanying commentary by Buckler. The article can be found at the following link.